Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Still on the topic of lung cancer, today we're going to be talking about the radiologic presentation of lung cancer. This is basically a summary of everything we've been talking about in the past, and we are going to look at what things should point us towards the possibility of a lung cancer in general. So the first thing we'll talk about is segmental or lobar atelectasis. Now, atelectasis is due to bronchial obstruction, and it's a very common presentation of lung cancer. Despite the presence of atelectasis, volume loss, which is usually the case in cases of atelectasis, is variable, and this variability of volume loss is due to the volume displacing effects of cells, because cancer is a growth of cells. So even though the lungs may collapse, you may have the cancer cells adding volume to the thoracic space. You may have excess mucus plugging, you may have excess fluid, and all those things may prevent you from seeing the effects of volume loss per se. Also, because of the bronchial obstruction, you may have obstructive pneumonia occurring, which is also a common presentation of lung cancer. Now, a little note. If you see multiple foci of atelectasis presenting at the same time, and you can't explain these two foci of atelectasis by a single endobronchial lesion, most of the time a benign process is more likely, like mucus plugging different bronchi, therefore you're having multiple areas of atelectasis, as opposed to a malignant process which would have blocked one major bronchi, and therefore you would have lobar atelectasis. Multifocal appearance of a single cancer is usually rare. So this case is a case of right central bronchogenic carcinoma, which infiltrates the right superior lobar bronchus and causes collapse of the right upper lobe with compensatory hyperinflation of the lower lobe. So we can see, pointed to by this red arrow, where the right superior lobar bronchus gets terminated and is infiltrated by tumor cells. Can see it abruptly cutting off here. Next is consolidation. Now, consolidation that is indistinguishable from pneumonia can be seen with cancers like adenocarcinoma. Although adenocarcinoma and pneumonia may appear very similar, adenocarcinoma is usually a non-resolving consolidation, and you'll also have near normal white blood cell counts. So you may give the patient some antibiotic therapy for a full course. After about 2 to 4 weeks, if this consolidation is still not resolving, you can say that it's most likely adenocarcinoma. So in this axial contrast enhanced CT, we see a right lower lobe consolidative opacity with air bronchograms, and adenocarcinoma is a major differential for this. We've seen this image before in the previous lectures. Then hilar masses are also a common presentation of lung cancers, specifically squamous cell and small cell carcinoma. Hilar enlargement may be as a result of a primary central tumor in the hilar region, or as a result of nodal metastasis, hilar nodal metastasis from perhaps a parenchymal neoplasm. The tumor in the hilum, or the mass in the hilum, may end up compressing and narrowing the bronchus, and then you could have cases of lobar atelectasis or obstructive pneumonia secondarily. So in these images, these are cases of lung cancer presenting as hilar masses. This first one is a frontal radiograph, and it shows a right paramediastinal opacity which does not silhouette the right heart border, and the CT shows a large right infrahilar mass here. The next thing we'll talk about is a superior sulcus tumor. A superior sulcus tumor is a lung cancer that is occurring in the lung apex. A big example is a Panco's tumor. That's a type of superior sulcus tumor, and this involves the sympathetic ganglia causing Horner's syndrome. Horner's syndrome is ipsilateral ptosis, meiosis, and anhidrosis. A superior sulcus tumor is a stage T3 tumor automatically. We'll talk about the staging of lung cancer in the next video. So in this image, this chest radiograph shows a nearly imperceptible increased opacity in the right apex up here, and this is evident on CT as a superior sulcus tumor which encases the vasculature and effaces the superior mediastinal fat. Then another presentation is lymphangitic carcinomatosis, and this represents diffuse spread of neoplasm through the pulmonary lymphatics. This is typically seen in late stages of the disease. So on imaging, carcinomatosis manifests as smooth or nodular interlobular septal thickening. It's often asymmetric. So in this image of lymphangitic carcinomatosis, we see asymmetric nodular septal thickening of the right lung throughout. You see all these thickened septi, which we don't see on the other side. And this was in a patient with metastatic uterine sarcoma. Finally, we'll talk about pleural effusion. Pleural effusions are relatively common in lung cancer, and they may be due to lymphatic obstruction or pleural metastasis. A malignant effusion is the presence of malignant cells within the effusion. A malignant effusion is an M1A lesion, and this precludes curative resection. Not all effusions associated with lung cancer, however, are malignant effusions, so it's necessary to have cytologic evaluation. So in this image, there is a partially necrotic mass lesion in the right upper lobe, which is consistent with a known history of lung adenocarcinoma. The superior vena cava is significantly narrowed as it traverses the lesion, and the right mid to lower zone demonstrates a large, likely loculated pleural effusion, causing inferior displacement of the adjacent diaphragm and elevation and collapse of the right upper lobe here. So this brings us to the end of this discussion. Our next and final discussion on lung cancer would be the staging of lung cancer. I hope, as usual, you are getting value from these videos, and if you are, kindly share, like, leave a comment, and subscribe if you have not subscribed yet. Thank you very much, and I'll see you in the next one.